Hi, everybody. My name is Danny Garcia, and I am a third-year resident at Wayne State Family Medicine Program. It's in Rochester Hills. I am part of the team that completed the Quality Improvement Project on pediatric lead screening exams at 1 and 2 years of age at Community Health and Social Services Center, also known as CHAS Center. My team was composed of many other residents and our supervisor, Dr. Towner. A little background of why we chose this QI project. Elevated blood lead levels in children less than 5 years old lead to headache, insomnia, and developmental delay. A lot of times these children have learning difficulties that are lifelong and prevent them from reaching academic goals that they may have. Children from underserved areas are disproportionately affected by elevated blood lead levels. This is very common to see in Southwest Detroit, where CHAS Center is located. Medicaid in Michigan recommends that all children enrolled should undergo blood lead level testing at 12 and 24 months of age. If that's not able to be done, between 36 and 72 months of age is preferred if they weren't previously tested. A little background on CHAS Center. It is a large community-based clinic located in the heart of Southwest Detroit. Its mission is to develop, promote, and provide comprehensive, accessible, and affordable quality primary health care and support services to all residents of the community. An interesting fact that we noted was that at CHAS, from 2018 through 2020, only 34% of children who were enrolled in Medicaid underwent blood lead level testing. We believe this number could use some improvement, and that was a big factor of why we chose this project. Our long-term goal was to eventually get to 100% of our children being screened for lead. Our short-term goal was just to improve it by 25%. So we did a fishbone diagram to determine the cause and effects of why we had such poor compliance. The main categories we chose were equipment, people, environment, and methods/procedures. I wanted to speak more about equipment because this is a big factor at CHAS. We do have a POC lead screening machine, which is a point of care machine that allows us to screen these children for lead bedside. It allows us to do it while they're in the physician appointment without having to walk over to a lab. This machine for us has been broken now for about a year and has not been fixed since. This has made us have to send these children to the labs, which a lot of times these children are waiting for an hour or two to see a provider, so they're fussy, they're non-cooperative, and what happens is a lot of times mother will choose to go home instead of walk over to the lab. The other thing too is that our lab's located in the corner of CHAS, so basically it's sometimes tricky to find. So these two factors alone just led to a poor compliance to lead screens. Our first PDSA cycle, we wanted to examine the impact of posting reminder signs at provider workstations on screening compliance. We wanted to compare screening rates in the 2 months before and after the intervention period. What we did is we had residents on the QI team put up signs for 8 weeks. These signs were colorful and easy to read, and they explained 3 things. The first thing explained was the detrimental effects that lead have in the blood of a small child. Number 2, it explained at what ages it's recommended to have the screening done for lead. And number 3, it had an order set instruction on how to order this on Epic, which is our EMR. After gathering data, we noted that we had a 17% increase in pediatric lead screening just by putting up these signs. This was very impressive. We were very happy with these results. We went from 34% to 51%. So what we decided to do is we adopted these signs. Till this day, these signs are hanging in the workrooms where providers write their notes and hang out. In order to better explore additional physician barriers and help better inform next intervention steps, we did conduct a small brief survey. This was a 5-item survey. It was completed by 80% of our providers who saw children at CHAS. 70% of the providers knew when lead screening should occur, but commonly reported barriers to acting on that knowledge and included when screening is done, memory, poor patient compliance, and blood draw for a small child is difficult because they have small veins. Suggested strategies to improve provider compliance with ordering blood lead screen. 30% of providers believe that hints on the templates when they write notes would be beneficial, and then 54% believe that an Epic pop-up would be beneficial. In conclusion, regular education and guideline reminders for pediatric lead screening is needed. This is hopefully something that will become a habit in all providers as they see it over and over and over, and could also help with the new providers who were to join CHAS at a future date. We would also like to follow up with providers to see if template reminders were useful. This would be very valuable information to us. We want to identify caregiver barriers to completing lead screenings as to why, like maybe a parent would choose to go home over take the time to take their child to a lead screen or any screen for that matter. And then addressing the aforementioned barriers will help us meet our short and long-term goals of increasing compliance with lead screens. This concludes my presentation today. I will pass this over now to Dr. Almonte, who will be answering all questions you may have. Thank you very much for listening to my presentation.